Call upon Dr. Reshma to enlighten us about the do's and don'ts in converting, in handing over to a retina surgeon, especially in the case of PC rents.
Thank you, sir, for handing over the topic. And thank you all for being here. And thank you, AIOC, for the wonderful opportunity given. So I hope that none of the anterior segments have to have this trauma of handing over cases to a VR surgeon. But of course, we are happy. And I have no financial disclosures. I would like to take you all through these headings like pre-op assessment, preparation, intra-op care, post-operative care, and revision. So whenever a patient comes to us, it is better that we identify these risk factors for PC rents, and anticipating a problem like prevents much panic in the OT. So if we are having like dense brown cataracts, hypomature cataract, traumatic cataract, aged patients, intraoperative floppy iris syndrome, high emetropia, posterior polars, eyes with phacodonosis, of course anticipate, and that leaves us with very few options of clear-cut cases. And if you have a pseudo-exfoliation syndrome, fellow eye of a complicated cataract surgery, eyes with transillumination defects, and previously vitrectomized eyes or previously injected eyes have much more risk. So the mandatory preparations in the OT are give a prior info to the VR surgeons for a standby case, and preferably these cases you can keep a monitored anesthesia care also. Now it won't be a topical phaco, we will have to give subtenons or local anesthetics. Check if the retina OT and necessary machines and instruments are ready and trained staff are available or not, and sometimes these patients are premium IOL cases, so we will have to, and otherwise also we will have to take a consent for a posterior segment surgery, and standby IOLs like RF IOL or SF IOL will be better. And you don't have to cry if we have a PCR, and it's a part and parcel, complication is a part and parcel of all the surgery. The science of PCR is already been talked about, so I'll just skip it. So this is a video where PC rent happens while IOL insertion. Probably the angle of the injector was slightly up while injecting, and that's why it's happened. So the key is to recognize the PC tear early, and early recognition reduces the chances of vitreous loss and drop fragment. So I'll go to the do's and don'ts. So do not panic and pull out the phaco probe, and avoid peripheral phacos, and no attempt should be made to retrieve the drop nucleus in the anterior segment. No attempt should be made to fish out the posteriorly migrating nucleus fragments also. All these will cause undue vitreous traction, and do not use pilocarpine if vitrectomy is planned for the same day. And avoid unnecessary trauma or stress to the corneal endothelium and iris. Stabilization of the anterior chamber is essential. When vitreous is present in AC, anterior vitrectomy has to be done. High cutting rate cutters and continuous engage and advanced technique helps to reduce the vitreoretinal traction. Cortical cleanup is done, and try to keep the pupil round and stabilize the IOLs. And we would require a tight wound closure with sutures because we have to place ports, so iris prolapse can happen on doing that step, and a prompt referral to VR surgeon is expected. So this is a video where a PC rent is happening in a phaco. Here the surgeon has recognized it, and he is not pulling out the phaco probe, and when he suddenly pulls up, even then you can see the extension posteriorly. This is a video of a whole nucleus drop. You can see it has gone behind already. Now these are the complications of a dropped nucleus: elevated intraocular pressure, uveitis, corneal edema, cystoid macular edema, and retinal detachments. And the indications for VR surgery intervention is that extensive inflammation can cause, so whenever there is an extensive inflammation, we put the patient on steroids, and even if after giving steroids for 2 to 3 days, if there is no improvement, we will have to do a posterior intervention. And if the size of nucleus fragment is more than 2 mm or more than 20% of the total nucleus is inside the cavity, it has to be removed even when there is no inflammation. And whenever there is a secondary glaucoma, RD, and endophthalmitis, of course VR intervention has to be done. The timing of definite surgery depends upon individual cases, a VR specialist availability, and small lens fragments can be safely observed for 1 to 2 weeks. Vitrectomy for dislocated nucleus fragments can be delayed up to 3 weeks without any significant difference in visual outcome. Delayed vitrectomy leads to the development of secondary glaucoma and corneal edema, so immediate surgery whenever possible is the key. And factors to be assessed before the surgery are integrity of the cataract wound and corneal clarity, AC reaction, intraocular pressure, and always the peripheral retina should be free of any tears because excessive manipulation might have happened, and also RDs. And if there is a choroidal detachment, we will have to postpone the surgery at least for a week and give steroids. So PPV can be done either as a hybrid technique or a 23 gauge, because fragmentome doesn't come in a 25 gauge vitrectomy. So removal of vitreous from the AC has to be done, and intravitreal triamcinolone can be injected to identify the vitreous and do a safe vitrectomy. So whenever a fragmentome is used, we have to do a complete PVD induction, because fragmentome doesn't cut the vitreous, it only does phaco. So sometimes soft nucleus we can remove with cutter itself, and here also cut rate of high cut rate and high suction can be sometimes used whenever it is in the posterior segment, and few drops of PFCL which will help the macula to prevent from additional fragment related injuries also. Light pipe can be used to crush the nucleus against the cutter probe, and whenever it is a hard nucleus, of course we have to use the fragmentome. PFCL flow technique can be used, and whenever PFCL is not available, the phaco power should not go beyond 50% and vacuum must not exceed 80. PFCL assisted levitation of drop nucleus and delivery via the corneal wound also can be done. Endoilluminated assisted chopping can be done, and elevating the nucleus with active suction with hard tip fluid cannula, bringing it up to the anterior chamber can also be done. So this is a video of a pars plana vitrectomy. Whenever vitrectomy is delayed, the vitreous will form a very dense fibrous adhesion around the nucleus, so we have to make the nucleus there mobile. And using the sparing technique, the nucleus is removed. Here the surgeon is bringing the nucleus into the anterior chamber, and it is taken out through the initial scleral wound itself. The rest of the videos here are almost similar, so I'll just skip it. And prognosis is usually good. The visual acuity is more than 6/12 in 60 to 80% of the cases, but a lot depends upon the initial management by the anterior segment surgeon. And pseudophaky status at the time of fragmentation was found to cause relatively less endothelial loss. Complications of phaco-fragmentation surgery are again glaucoma, corneal edema, persistent inflammation, RDs and CDs. IOL drop, here also we will have to do a complete PVD. PVD induction is mandatory, and peripheral examination has to be done with indentation, and no fishing of the dropped IOL has to be attempted. And we can here also we can use the PFCL flow technique. Here always we hold the optic and not the haptic. This is a video of a IOL drop retrieval. We are trying to hold the optic here and not the haptic. Here we can use PFCL, fill the chamber entirely with PFCL and also float the IOL up. Now it is shifted to the anterior view. With the help of the endoillumination, we can support the IOL and bring it up to the AC. So always we have to revisit and learn what happened and how the complication happened, so that is the key. And take office and home points, because always the complication follows us to the home also. And do not panic, don't do any fishing, prompt VR referral is expected. And retinal detachment awareness can be given to all phaco surgeries, but this is not always possible in India. And so I express my courtesy to all the other instructors and my chief instructor, and for the content Dr. Monica Kapoor, and for the videos my colleagues have helped, and all my mentors and hospitals where I have worked, and all my patients. So thank you for your patient listening.
Thank you, Dr. Reshma, for that very illustrative demonstration of how exactly when we hand over a case, you're going to handle it. You have nicely put it on us that the final visual acuity depends on how the anterior segment surgeon is dealt with in the beginning. That was nice. Okay, now we have a few time for a few questions. We have 10 more minutes. Yeah, Dr. Matthew, for your comment.
One thing that I would like to highlight before we move on from the VR surgery topic is the consent is typically for an anterior segment surgeon, and you have taken a consent. So if a second surgeon is taking over the case, which is a different subspecialty, actually we need medico-legally to have a separate consent for that one. So if it is not possible, at least a oral consent at that stage when the VR surgeon takes over in the same sitting, and immediate post-operatively probably in the to complete the medico-legal formalities. So if it is a two-stage procedure where the anterior segment surgeon places the lens, sutures the wound, and then the VR surgeon takes over, that is not a problem. But it is the same sitting situations where typically you will not have a proper consent from the VR surgeon, and that is going to cause problems for you later if it is going to court.
Thank you, Matthew. Are there any questions from the audience? Yeah.
So, as per NABH requirements and the national guidelines today, you have to have a separate anesthetic irrespective of what is the nature of anesthesia. Even if it is a topical anesthesia, there should be a pre-anesthetic checkup, immediate preoperative reassessment of the condition of the patient, and if there is a change in anesthesia plan from topical to subtenance or peribulbar or general anesthesia, then that has to be documented. Consent for this is not by the ophthalmologist, should be by the anesthetist involved in that. Oh, in my cases of topical phaco, I continue with topical SICS only. Okay, all I do is just place paracaine bud on the area where I'm incising. Okay, as long as you are not holding that conjunctiva area very tightly, most people will tolerate this. Caveat is that it should be a new, very sharp crescent blade, and it should slice without macerating the tissue. No, I don't typically make a conjunctiva. It is a transconjunctival dissection. It's more difficult initially because you can end up with a partial thickness scleral, the cut through buttonholing of the sclera. But with experience now, I'm quite comfortable doing it transconjunctivally. Buttonholing will typically happen only if it is not a good new blade.
But we can also give we can also give subconjunctival anesthesia or subtenance in the infranasal quadrant if it takes longer time or something. Sir is very experienced, so he does under topical. But we can also give subconjunctival anesthesia or subtenance. Subtenance, if you are giving, we should go in the infranasal quadrant and inject about 1 ml, and then keep that. Initially, you have to inject a little subtenance xylocaine so that the conjunctiva get anesthetized, and hold lightly, and then nick with the conjunctival scissors. And then infranasally, you have to go posteriorly and inject around 1 ml of xylocaine, and you have to keep the flap closed so that it stays there for some time, and then you can go ahead with SICS.
In fact, it all depends on how comfortable you are. There are a lot of surgeons who do temporal topical phaco. If it happens, topical SICS. For him, I mean, if he's got a rent, it doesn't matter. So once you are experienced with that, then it's fine. What Dr. Matthew says, he does it routinely. Whenever he wants to, he starts, and without even an SICS, he does it in the same way. So he is experienced that way, doing it. So he is confident doing it that way, even in a regular cataract. And so when it comes to possible nucleus drop, etc., his hands don't shiver, and that's not a new technique. But you should never do it for the first time when you have a complication. That's all what I want. Yes, most of the time, yes. Because especially when the AC deepens, it's not while removing the nucleus excess, especially when the AC deepens, that pressure on the zonules and the iris, that can be avoided. And second, even the iris, for whatever reason, accidentally if you touch, most of the time you don't touch, it will be better. Yeah. That's
Most
a
of
good
the
idea.
time I use intracameral preservative-free lidocaine when I am operating under topical. And then we have got this phenocaine plus that has got phenylephrine also, so it will take care of the, if the pupil is not dilating well, you can use that. So it will take care of pupillary dilatation also.
Dr. Reshma, would you, when you are trying to take over topical phaco and you have a nucleus drop, what kind of anesthesia will you use? Would you want, most of the time we operate without any cardiac standby. So would you have a different technique? Would you go for a peribulbar, subtenance in these cases, or you will go for a block?
We can go for a subtenance also, and also a peribulbar would be fine. Anything, whichever the surgeon is comfortable with.